Bismillah ar-Rahman ar-Rahim. So our talk is about a novel technique about using calcaneal plate in comminuted posterior wall fracture. First of all, posterior wall, regarding the anatomy, it is not a long bone pillar as the posterior column. It's a wide, curved, circular area with tapered edge. So the posterior wall configuration and geometry need only not contour the longitudinal buttress. It need a horizontal or radial reinforcement for this fracture. Many reports in the literature showed fixation failure of the classical methods of posterior wall, and so many studies emerged to show different types of fixation later on. The option of fixations in the literature was the classic plan, which is the ischium to the ilium recon plate with lag screw. The problem in this and the disadvantage of this method that there is extensive soft tissue and muscle dissection to reach the inferior ischial pool. In addition to the contouring difficulty, especially if the fragment is located extended to superior acetabulum. Some reports suggested adding 1/3 tubular spring plates. However, multiple hardware will be added to this area. Some studies talked about T-plates, mini plates, cervical plates, or pilum plates, even anatomical plates, but all of these have high cost and can be difficult to be used in different anatomical shapes. This is the ordinary calcaneal plate, which is familiar to most of the orthopedic surgeons. We looked to it and divided it into two parts. Two triangular zones. A distal part has C-screws in the triangular fashion, and a proximal part which is V-shaped with radial and longitudinal direction. So it acts as a buttress mesh over the comminuted fragment with multiple anchorage points in longitudinal and radial direction. And the most important thing that we didn't need to use full dissection of the ischial tuberosity, as we can see here in this saw bone. So actually it acts as multiple mini plates which is connected together in one construct with very high versatility that accommodate any size or site of the posterior wall fracture. Over 4 years, we did 22 patients via cochlear approach after proper exposure and fragment reduction and fixation of every fragment with K-wire. We dissect only to the upper end of the ischium, and we applied the lower end of the plate to it and have 3 screws in the ischium in triangular pattern. Then we contoured the wings to ensure full coverage of the posterior wall area, fixing every fragment specifically by screw and using a suitable size plate. Our results showed that there was no loss of reduction or fixation failure through the follow-up period of at least 1 year, with accepted radiological and functional outcome, and no iatrogenic sciatic nerve palsy was reported post-operatively. For a case example, this is a comminuted posterior wall case. We applied our calcaneal plate, 3 screws in the distal part in a triangular fashion, and contouring the wings of the proximal part in a V-shaped manner to cover the area. And this is its X-ray at the final follow-up with complete union and no fixation failure. Other case, immediate post-operative, 3 screws in the ischium, contouring the proximal part, and at the final follow-up. So we say that the calcaneal plate is low profile, slim, easily contoured, and can be oriented circumferentially around the acetabular rim. It has a large malleable footprint area with multiple lag screws from the multiple holes. It can even buttress the small fragments that avulsed from the labrum of the osteochondral junction and we can avoid using anchors in this case. The most important thing is the ischem sparing, so there is no intraoperative neurovascular insult or ischial tuberosity, sitting pain or irritation. Is a cost effective, and if we use locked plate, it may also give subangular stability. We reached a comparable results according to the literature regarding the radiological and the functional outcome, and we believe that as a calcaneal plate buttress the blowout wall in the calcaneal fractures, resisting the axial load of the ankle joint, we also believe that it resembles its ability to buttress the posterior wall, resisting the dislocating hip force. The limitation of our study was a small number of patients, short follow-up, absence of comparative fixation group, also absence of any previous biomechanical or cadaveric study that elaborate the biomechanical strengths against this dislocating force. Alhamdulillah, we succeeded in publishing this technique 2 months ago in the European Journal of Orthopedic Surgery and Traumatology. So to conclude up, using of calcaneal plate is a suitable option and good alternative to the ischoilial recon plate. It's reliable and cost effective, safe and easy, with loss of tissue dissection or implant irritation at the ischial tuberosity. We can apply 3 ischial screws in a triangular manner, anchoring the plate firmly to the ischial area with a V-shaped anchorage proximally covering the posterior wall. So it acts as a wide tailored metal mesh. It hits a new ground, but it needs comparative studies with other fixation to validate our results. Thank you very much.
Thank you very much. Next up, we're going to go to the